afternoon, everybody. Welcome to a Wednesday afternoon webinar, PCNA webinar. Thank you, everyone, for joining us. I think we've got a topic that's kind of capturing everyone's attention because we've got quite a few registered for this webinar. If you can, I know that many will be at work, many will be in the car, probably parenting or cooking dinner or something like that. But if you can turn your camera on, it just helps Jen and I feel like we're not talking into an abyss. Thank you, Chitra. Thank you very much. Thanks, Michelle. Thanks, Lisa. Oh, there's a whole room of people there. Um, Look, we give everyone 1 more minute to join, and then we might get started. If you can, pop in the chat where you are joining us from and your role. Actually, interestingly, thank you. Hi, Kirsten. Hi, Lisa. Hi, Michelle. Interestingly, we've had many nurse practitioners register for this webinar. So it's obviously something, yeah, that nurse practitioners is very interested in, very relevant. So I think we get going. Hi, Lizzle and Chitra, Monique, all from all around Australia, South Australia, Gippsland, Queensland. This is my favourite part where we're all joining from everywhere. All right, let's get going. So welcome and good afternoon, everyone, and welcome to another PCNA webinar. So my name is Sarah and I am a palliative care nurse and I'm currently living up in Darwin and I'm on the PCNA steering committee. So I'd like to start by acknowledging the traditional owners of the land that I'm living on currently, which is the Larrakia people. And I'd like to recognise their continuing connection to the land, waters, and to their culture. And I pay my respects to the elders, past, present, and emerging. So these sessions at PCNA are about supporting palliative care nurses and our broader nursing workforce. So today's webinar is on nurse prescribing, and it's obviously captured the attention of a number of different people because we've got quite a few different nurses joining us today to hear from Jenny, and I'm going to introduce Jenny in a minute. Before we begin, we've just got a few housekeeping bits and pieces. Please use the chat function today and really particularly for this webinar, because Jen's going to start by giving us a kind of a lowdown on nurse prescribing, but then we're really going to hand it to you guys. And so as she is talking, please put your questions in the chat and we will ask them, and we'll get a good conversation going because Jen will have the answers, or at least we can have a conversation about the answers. Closed captions will be enabled. So if you would like to use that, you can. And this webinar will be recorded and you can watch it after the webinar on our either member exclusive channel at PCNA or on our YouTube channel. We'd also really appreciate your feedback, and there will be a survey that will pop up at the end of the webinar. And so any tidbits about what would be useful to improve, we'd really appreciate that. So I'd like to welcome Jen. Jen, give us a wave all the way from Wagga, New South Wales. Now, you know you're from Wagga if you say Wagga, and you're not from Wagga if you say Wagga Wagga. So you play your cards as soon as you say it.
Yeah.
Now, Jen, just before you say hi, Jenny is a nurse practitioner who works in the Murrumbidgee Local Health District. And Jenny was just telling me that she has clocked up 20 years as a nurse practitioner. So we are lucky to have Jen with us today. Thank you, Jen, for being with us.
Thank you very much. I'll just share my screen. I'm from down on the beautiful Wiradjuri lands. Go from there. My words aren't going to work terribly well at the end of the day, but hopefully Sarah outlined. I'm just going to start with an overview because obviously this is something very new. The concept of nurse prescribing has been around for quite a few years, but with anything that takes changes to multiple legislation and getting lots of people on board, it takes time to implement. So it is a bit of a moving space. I've been watching it quite closely, probably for at least 2 or 3 years now to see how it will land, because I am quite curious about it. I have a caveat. I work for New South Wales Health and my work's regional, rural and remote. And so by that, when I say that, I am deeply influenced by where I work, and that certainly has influenced where I sit with this nurse prescribing, with registered nurse prescribing. I'm not an expert. I don't think anyone's an expert yet, because we haven't had it in Australia, but there's quite a few of us that are interested in it and want to see it happen. I'm a devout pragmatist. This is here. We need to work with it, and I view it as a real opportunity for nursing to grow ourselves, and be as disrupt as we can be to the healthcare system to get the best outcomes for our patients. And that, at the end of the day, is what we want. The goal of this session is to be a catalyst for reflection. In all reality, yes, there's some courses available to start getting trained up, but there's a lot of back work behind this before someone can pop themselves up and say they're a registered nurse prescriber. And I think, to me, the most sensible and is knowledge is power, to get ourselves, or whoever who's interested in doing this, to get yourself in a position that where it really starts to get rubber to the road, you're ready to go. You've had to think about how you might contribute. These are my views as an individual with an interest. I sound like I'm a financial planner now, don't I? I'm not a representative of New South Wales Health for this topic. This is my views from the research that I've done and my interest over a number of years. Okay, so don't mortgage your house on or anything like this. This is just I think, a considered opinion. This is straight. So what is registered nurse prescribing? And this is the definition that's on AHPRA and the NMBA websites. And they are the first things that are going to be your friends if you are truly interested in pursuing nurse prescribing. So designated nurse RN prescribing, I'm going to just use the word nurse, and know that when I say nurse, I'm actually meaning registered nurse, not EN or anything else, or nurse practitioner. When I say nurse, I'm alluding to a registered nurse prescriber for this today. Otherwise, I'm going to wear my voice out, keeping repeating those three words. So nurse, it requires when a nurse with an endorsement to prescribe for scheduled medicines undertakes prescribing within their level of competence and scope of practice. And they must do it in partnership with an authorised health practitioner under a prescribing agreement. And that last part of that little paragraph is key, and that's what actually makes it different from nurse practitionering, which I'll get to a bit later. The designated nurse is responsible and accountable for prescribing within their scope of practice and authorisation. So babies, it's on you. If you're a nurse prescriber, if you happen to do something with your prescribing and you have to actually be able to defend and say why you prescribed what you did and how you did. It's on you. You can't blame it on your mentor, unless, of course, the mentor's written you advice, but, there would be reasons you can. But essentially, like all of us, we are accountable for our actions, and nurses have been professionally accountable for our actions since the 1970s. It's been a long time since we've worked under the auspices as the doctor said goes. It's our job to actually evaluate with what's been said to go is worthy and safe for the patient and following through. So we are accountable. So RN prescribing has been implemented safely in the United Kingdom and the USA for decades. The USA started in the late 1960s, in fact 1969, before I was born. New Zealand commenced RN prescribing in about 2016, I think it was. So it's been safe over there, and theirs looks a little bit different to the way Australia's doing it. It's very much grouped into community prescribing or primary health and specialist. And for Australia, non-medical prescribing commenced in 2021 when the nurse practitioner role commenced. And I think from my angle of being around, so I was endorsed in 2006, I should say, having seen the growth and how that's evolved, I think there's been a lot of lessons learned from the way nurse practitioners are introduced that they've used to actually hopefully have the nurse prescriber come in at a more gentle, sustained pace that actually shouldn't hopefully lock and bog people down as much as it might have done when I was a baby nurse practitioner. This is a direct lift from the AHPRA thing, and I've just done it directly because you can look it up. If you go to AHPRA, there is several sections on fact sheets and different things that if you're interested in this, might become your Bible as alongside the state framework that you'll see, which every state will have one coming out soon if they haven't already. So registered nurses, there's no endorsement, they can't prescribe. Having said that, I know there's different protocols around, like ECAT in New South Wales, and there's different remote area nurses that registered nurses who are suitably qualified can prescribe understanding protocols or, deliver medicines over there. So that's where that sits. A designated RN prescriber, you have to have an endorsement. So you've got to get an education. There is two pathways, but I'm going to focus on the postgraduate way of doing it. You've got to get the qualification. You've got to have the right number of hours to apply. You've got to be authorised by NMBA, the Nurses and Midwives Board, and then you've got to actually have your employer also be in agreement as well and be able to work with you to get a job. Nurse prescribers, if you look at the bottom line, and this is the important difference, are prescribing within a clinical governance framework under an agreement in accordance with your state hoo-ha, your law and things like that. So it's a framework under an agreement. If you look across at nurse practitioners, we're able to prescribe. Sorry, can we just mute, please? Whoever's not muted. We are autonomous, so we don't work within a prescribing framework, although I think some states still have more limited formularies for nurse practitioners. We don't in New South Wales. There's one nurse practitioner formulary for all of us, and you just work within your scope. So as a palliative care nurse practitioner, quite obviously I prescribe all my stuff for palliative care, but if I wanted to prescribe, say, birth control pills, whoever was dispensing that script would be well and truly within their right to actually question why I was prescribing birth control. Because let's face it, it's not usually a medication that's required at end of life. But if I justify it, it's because there's someone who's moving towards that and has uncontrolled vaginal bleeding or something like that, I can then prescribe it. But I've got to be able to justify my decision making. Okay, so I think gets a bit wordy, but that's probably the main difference between what an RN prescriber and a nurse practitioner, and it is an important difference. It's the scope, just how much you can do, and just how much. I mean, the oversight's always there. The prerequisite as it sits is 5,000 hours of initial post-registration clinical experience in the last 6 years. So that's the same as your nurse practitioner, or same for RN prescribing. And you need to have successfully completed the NMBA approved RN prescribing course, and you must have clinical mentoring with an authorised health practitioner for the first 6 months. That's the bare basics. It doesn't sound like much when you put it on paper. I'll be the first to agree. So you've done all that because it looks pretty simple. Can you now prescribe? The short answer is no. And that comes very firmly through the governing documents from AHPRA and the Nurses and Midwives Board. And certainly the New South Wales Health have just released the framework for registered nurse prescribing. That's out for comment at the moment, and it's very clear that that's a no, that there actually has to be a clinical governance framework and some agreements with your employer. And I think that's actually not a bad safeguard in all reality. Employers will determine the roles and responsibilities of RN prescribers. And this, again, can't comment for every other state in Australia, but very much what New South Wales is looking at, and I suspect the way this has happened in Dove Step, the states have gone together, that's why it's so slow. They're really focusing on rural, remote workers, and certainly those of the specialty. I think when I was going through a lot of the examples around prescribing in New South Wales, it often uses palliative care or renal as examples of where a nurse prescribers can fit. So as nurses with either a very strong interest in palliative care or those of us who work in specialist palliative care, I think we're in a really great place that this may become a fantastic tool in our toolbox. Clinical governance frameworks, a lot of that's around the prescribing agreements and scopes of practices, and again, it will come down to your employer and how they choose to run this. So I'm going to talk a bit more about New South Wales-centric approach, but as I just alluded to, I think when I first really started to hear, I first heard about prescribing probably at least 10 years ago, but it's rumbled along since then. And I think one of the reasons the process has been so slow is they've really tried to approach this at a national level. So theoretically, I think any framework across Australia will look very similar to what New South Wales has done. I'm sure there'll be some quirky differences because people always have to be a bit quirky and stamp their own on it. But from what I can gather and looking at the New South Wales framework, it is very, very, very closely aligned with the original founding document from AHPRA and NMBA. And I suspect it will be the same. So forgive me for my New South Walesness, but this is what I know. The framework that they've released is got a very strong governance process. It is extraordinarily strong and it looks good, and I think it will be good to work within. So it really clearly sets out what the nurse practitioner, the nurse prescriber is, the limits of the medical conditions with which they can prescribe for, and lists of medications which they can prescribe. There's very clear guidance for obtaining endorsement. There's no wishy-washy there. That's what it is. And they've got templates for the prescriber agreement, the mentoring agreement, and everything, a formulary, a scope of practice. So it's everything you need. And I think for me, looking at that, I felt a deep sense of relief, because when I was first endorsed as a nurse practitioner, getting a scope of practice through every man and his dog that had to have a comment on it was incredibly difficult. And New South Wales has really worked hard to streamline that over the last 20 years. And we now have a very firm, tight scopes that everyone signs that can't get bogged down in governance committee and local health districts. So I think that's a really strong lesson that they've learnt from all those years ago. There's guidance for mentoring and mentoring agreements. And when I say that, when we talk about mentoring, I don't know whether any of you guys have ever entered a formal mentoring agreement. The news is, if you're the mentee, the person receiving mentoring, it's all on you guys, as it should be, because you're the ones who are looking for the guidance from someone who's already got the skill base. So my thing is, you've got to find the person that you can relate to and basically chase them down, because that's your job as a mentee. There's certainly the guidance. It's also got stuff there for if the mentor-mentee relationship isn't working, if there's differences and stuff like that. They've actually got a bit of a get out of jail clause and guidance to help people work through that. The other thing that's on here that I put as New South Wales centric, but it's actually not. The decision assist tool is something that AHPRA actually lists, and what it does is actually give some guidance to an LHD, or however you frame your local health districts in your state or territory, the need for an RN prescriber. And I did say at the start, and sorry to single out, I know there's like Rest Haven in South Australia have a big organisation that really supports palliative care. So it will be within, say, your organisation to actually decide that what a registered nurse prescriber can do. Is there enough work? What kind of work do they want you to do, and how that will fit in with the rest of the team, things like that. And I think it's a great tool because it should cut down on a little bit of the nonsense that may have happened when nurse practitioners started, that people were putting forward for endorsement to become a nurse practitioner for pacemaker adjustment or something, when in reality that's a job that can be done by a non-clinical technician. So, and there was some wild and wonderful titles in the early years, which now they've really started to bring into probably a little bit more sensible kind of alignment. So it's not quite as narrow in the focus, because there's no point employing a nurse practitioner or a nurse prescriber who will only deal with a very narrow focus of conditions. It's a waste of an employer's time and money in all reality. And I don't know what we'd expect you to be doing all day either. It'd be quite a boring job. There's also a template there as well for a prescribing agreement. So that really clearly sets out the expectations from both sides of the fence. And so hopefully an RN prescriber won't feel like they're left out in their own unsupported with some of the decision making. As I said, authorised medical conditions. So with palliative care, obviously, for us, it's quite simple. It's anyone with a life-limiting illness. So our potential is quite broad, but depending how you're structured, you might be someone who looks more at motor neurone disease or heart failure or something. So your conditions, medical conditions, may be then funneled in line with the work that you do most days. It kind of makes sense, because you become a lot more of an expert on a smaller area, and that certainly makes you potentially at this point a safer prescriber. They also say there's a formulary there that you put we used to call them, I think, was it P drugs in nurse practitioner land, where the drugs you're most likely to be prescribing got put on a list, the hows, the whys, the doses, etc., and they got signed off by drug committees. Pleasingly for me, and for all of us who work in palliative care, there's S8s are on the table, which I think is great, because certainly, yes, S8s are on the prescriber from a state level when we started as nurse practitioners, but it took till 2010, I think it was, or 2009, to actually get access to PBS to be able to prescribe them, that we weren't going to cost the patient a small fortune. There's guidance for continuing medicine. So there's going to also be some rules in there about what is going to be allowed in within that particular RN prescriber's toolkit, and the partnership and stuff like that. So that's very firmly there as well. Scopes of practice some people can look at them as being quite a limiting thing, but they are the gift that keeps us going. It puts the boundaries down around us of what we work. All nurse practitioners work under a scope of practice, and it clearly sets out who we see, what we see, and how we see it. And things like that. It can be protection if you have a demand from someone else who wants you to see a patient. If it sits outside your scope, it sits outside your scope and you can say no. It also enables an individual's personal decision making. If there's something you're not comfortable with, that you've not been trained in or you've not seen before, that you can actually say, no, that sits outside my scope. I'm happy to prescribe in that situation in partnership with someone else. I use that clause all the time because I see kids as well as adults, and I prescribe for children in partnership with paediatricians. Although I've done it many, many times now, I still feel much safer in my prescribing if I have someone riding shotgun with me. And I think that's a safe thing that we all should be looking at. We've also got to make sure that our scopes protect our consumers and protect us as well. No one wants any of us to end out in a clinical review because there's been an adverse event or in a coroner's court that you have to defend why you prescribed what you did. And certainly that's what the scope's there for. And they need to be broad enough to allow clinicians to practice freely, but it also has to have some strong boundaries there so that when you, as a registered nurse prescriber, working under an agreement, that you're safely protected, that you're not going outside of that. So if I suddenly said to my RN prescriber, I'll just prescribe XYZ for a child, they would be fully in their rights unless they're pediatric trained to say, no, Jen, that's not in my scope. I'm not doing that. And that would be the best for the person, because that would wake me up to what the devil am I asking someone else to do. Boundaries and accountability is always important. And I guess this is something that people can get a little bit concerned about, that the RNs won't have enough. But I've got enough now, some qualification to say when something's outside my scope. We are all professionals, and that's the expectation of that RN prescriber would be to say, that is outside my scope. I don't have this, because that's your part of your clinical responsibility as well. So that's my brief overview. My mate Cocky there would like to know if you've got any questions. Hopefully left plenty of time for questions, Miss Sarah.
You have. You've done very well, Jen. Thank you for that. I have questions. And so what I might do is I might start off, but while I'm asking my first one or two questions, if there's anyone who's listening, pop your questions in the chat, because this is the time, and Jen will be able to at least have an attempt at answering them. I've got two, Jen. The first one
Fire away, Sarah.
My first one is around the clinical governance framework. Just for my own, kind of for my simple brain, just tell me what that is. Is that like a thing that says this is how you'll fit into your system that you work, and these are the specific drugs you can prescribe? Is that what that is?
Honestly, yes, that's basically what it is. And governance group, again, that's an adoption from Nurse Practitioner land that we certainly in New South Wales, and I'm getting the impression it's across Australia, that there are these governance groups that are set up just to oversee some practice. And it's not overseeing your everyday, but it's things like a group to sign off scopes of practice. It'll be a group to approve, to say yes, that the decides tools being used and there is a need for this person to become an RM prescriber in our service, and it would give the support for that person to continue and say yes. So you don't want to be like I said, it's designed just to put up a solid framework and safety net beneath you. And also maybe the way to have your formulary signed off for an area drug committee. If it came to me and it's a palliative care nurse who's doing it, I'd be able to have a quick look at the formulary and say that all sounds very reasonable for someone who's prescribing within palliative care. Then it would get sent off and rubber stamped, and the nurse prescriber's good to go.
So it's a little bit of scaffolding. It's kind of a little bit of scaffolding to help you get it across the line. That sounds very useful.
I think it's useful, not to be scared of. It's not governance as in you're a naughty person. It's purely there for a scaffold. Nicely put, Sarah.
My other question is about the RN prescribing course. You may not know anything about that, but do you have even a vague idea of what that involves? Are we talking like a year's course? Are we talking part-time? Are we talking intensive? It's okay if you don't know the answer to that one, Jen.
No, I have looked at that, Sarah, and there is variance amongst them. And they do seem to go from semester to I think I saw one that was proposed to be a whole year. There is
Okay.
variance in them, and this is something for me is a bit of a problem because none of the information out so far says that you need a postgraduate qualification in your specialty before you proceed. Now, to me, as a prescriber, to prescribe safely, you've actually got to know a bit about your conditions, your symptoms, and what you're prescribing for. Yes, you might have many, many years
Totally.
experience, but there is nothing quite like doing some education to actually to question why you do what you do and what the evidence is for it. So I think at the moment when I looked today, because I checked, the only two, I thought there was a third course that was approved by APRA, but at the moment there still sits two on the website, which is La Trobe University and Melbourne University. La Trobe seems like a more comprehensive course right now. This is not a recommendation. I've never studied at La Trobe, okay? But they seem,
Not a
because
sponsoring
they've
webinar.
also,
Yeah.
yeah, I'm not sponsoring anyone, but they seem like that they offer a course on pathophysiology as well.
Okay.
So to me, that looks quite good, whereas Melbourne's doesn't. So my thing would be if you're thinking about becoming a nurse prescriber, line your ducks up, peeps. Have a look what you've got in your postgrad bag and maybe think about if you are a palliative care person, do your palliative care postgrad. If you work predominantly with older people, please, please, please do a postgraduate on looking after older people. They're not just they're not just big adults, realistically. They deserve a different focus for prescribing than someone who's in their 40s or 50s or younger. So they're a bit different. I think there's more coming online because if you do a Google search, there's lots more listed, but these are the only two that currently are on the APRA website as being endorsed.
Okay, Jen, thank
And
you. And we've got good news, we've got questions coming in, and I'm just going to reassure
great.
everyone we've got enough time to get to everyone. So I promise we'll do that. I'm just going to start from the top. So we've got one question from Aileen, and Aileen says, "Is the formulary likely to be more limited than an NP? Um, and can the mentor be an NP?" And there's actually another question in there about mentors as well. Can it be a G? Does it need to be GP or an NP? So two questions really.
Okay, formulary will be much more restricted than a nurse practitioner. So it's limited by, and certainly it comes through in the framework I've seen, and it is mentioned in the APRA and Nursing Midwifery Board as their stuff as well. So it's very limited to prescribing to the conditions that you've been endorsed for. So as a palliative care person, you'd have the full run of antiemetics, analgesia, benzos that are commonly used within your service. So it would be no good, someone who works remotely to be probably listing things like cyclazine or some of the levomepromazine easily if you can't get it where you live. You've got to, so it's got to be within your context of your practice. So I think, Aileen, yes, it will be more restrictive because in all reality, and I think if someone's working as a rural generalist or working eventually for a primary health situation, theirs will be broader. So theirs might contain the commonly used drugs to treat a UTI, to treat hypertension, to treat whatever the common things that they might see in that particular clinic. So it will be very much limited. And I suspect palliative care ones may look quite similar, but each service has got its own culture of what they use as first line, second line, etc. So there will also probably be a bit of flavouring from whoever the person's mentor is.
Okay.
Hopefully that answers that question. And it is interesting in New South Wales, certainly, and I'm sorry to keep referring back to that, but that is the one I know. They actually have it down as two. I'm just looking at it now. They have it down as two formularies. So one's very much for S8s and one's very much around business as usual medications that are related to a medical condition and
Right.
things like that.
And then the question that's come out in a few of the chat questions, Jen, is who can be the supervisor? Is it an NP? Is it a GP? Does it need to be a geriatrician? Do you have any information on that?
It can be a nurse practitioner or it can be any form of VMO. And I think it comes down to the context of the medical person or I'll just say prescribing person because it's much easier. And when I say prescribing person, I mean GP, I mean VMO, I mean nurse practitioner that you closely work with. Again, at
Mm.
the moment, what my feedback to New South Wales Health was, it hasn't got a experience limit on nurse practitioners. And I believe, and it should be the same with doctors as well, that they need to actually been out for 3 years and actually practicing prescribing themselves for at least 3 years before you become a mentor. Because I
Okay.
think what a pressure. You've just got to you've done your masters, you've got your endorsement, you've got to the end, you're just learning how to prescribe yourself, and suddenly you've got to prescribe, support another newbie to prescribe. I think that's a burden that's a step too far away, and it's not fair on either of you. You, the mentor, or they, the mentee. I think it should fall to someone else at this
And
point,
then,
and that's
and
the
then
feedback
Jen,
I've given.
sorry, and then actually
You're right.
narrowing it down even further, do they need to be in the same organization? And you may not know the answer to that.
Oh, I don't know the answer to that one. That's a bit tricky, but I imagine like nurse practitionering, no. But it would make more sense that they are because the governance frameworks are with your employer.
Yeah.
So it would depend, and I would think it would be very sensible. It's going to depend on numbers that within an organisation that you'd look at having mentoring groups that, you bring all your nurse prescribers together quarterly or something just to do a bit of a check in, how you're going, any issues, because let's not assume that this will sail through. There's going to be glitches here and there, and people are going to need support to get through that.
Yeah, no, totally. And look, and I guess every organization is going to be a little bit different about how and who is willing to support. I actually in the chat there's a kind of a comment slash question from Chitra saying that I'm going to read it. She says, this is like nurse prescribing in a capsule to swallow. So I think that's like the ultimate compliment, Jen. Good job, Chitra. Thanks,
Thanks,
Jen.
thanks, Chitra. I
She
hope so.
said,
It's a bit complicated.
yeah, it's awesome. She said, I'm a new grad MP, obviously still waiting for my job, and would
Oh,
like to participate voluntarily here to contribute to policy and feedback.
mm,
And
yep.
she said, however, I'm unsure of the medical reception to this. And I guess that's the question is, I think that comes from that is how do you approach it if you're within an organization that you think might find this hard to swallow?
Challenging.
Yeah.
My thing was, and it's the same with nurse practitioner roles, and I'm so pleased to see over time we've got more professional in our approach. So if you were a registered nurse or whoever working and you think there is a need for you to be able to prescribe and do this, get your business case together. Okay. Who are you going to see? Why are you going to see them? The benefits for that patient. And work from that angle. And I would really work from the benefits of the patient. And I think this is where, if any of the listeners are actually based in more metro services, I suspect nurse prescribing is going to get a lot trickier to get through. And certainly, again, New South Wales, sorry guys, but again, that's where New South Wales Health focus is to start it in the regional, rural and remote first because there's a greater need there. My thing is I always make sure, we work in collaboration, and this is yet another collaboration. So if I do a script for someone, if I'm doing a letter, it's usually I took the liberty of furnishing a script for this person. Da, da, da. If I'm talking to them, I know you're so busy, so I thought you wouldn't mind. I just did this script while I was there today. So it's really about keeping relationships, which nurses generally do very well. I think there is a risk here, and personalities will do this, that they'll step out and go, oh, I'm a nurse. And I've seen it with nurse practitioners that are early as well. I'm a nurse practitioner. Everyone love me. No, darling, they're not going to love you automatically. You've actually we've got to prove our worth. And that's what this is going to be. So I think at the start, good selection of people that go through is going to be good because once you sneak a few people in under the blanket and they start doing good work, the snowball effect occurs.
Mm.
I personally have only ever had in my 20 years, nearly 20 years of prescribing now, I've actually only had trouble with a couple of doctors over time and only one consistently. Others, once they worked out what I could do, they actually found me useful. So I think it'll be okay. It's just I can see it being a little bit exciting at the start as they work out that no more nurses are prescribing.
Yeah.
Yeah.
Okay. Look, and I think
Nurses may be a little bit more restrictive, to be honest, because you do get nurses, you get a bit of feedback that isn't so kind sometimes. Mm.
And I think with all these things, time helps, doesn't it? And a bit of patience, that the
Mm.
system needs to adjust to something new like this. But I actually,
Yep,
at the core of it, is something excellent,
yep,
and useful for the patients. Um,
yep.
I had a question, Jen. Look, I guess I wonder. I know there are nurse practitioners who obviously joining because they're trying to figure out where they fit within this. But then I guess if there's someone who's joined and they are newer palliative care nurses and they are thinking to themselves, okay, what do I do? Do I choose? Do I, they want to be an advanced clinical nurse and they think, well, maybe I want to do, how do I choose who's suited to nurse prescribe? And who do you reckon is suited to nurse practitioners? Or maybe,
Yeah.
yeah, any thoughts about that?
I think it's your context of where you work is probably going to have the biggest influence.
Okay.
And also the personality of the person. I think it will become a handy adjunct for people who want to become a nurse practitioner that, they get their job, they get their 3 or so years working in a specialty, they get their postgrad under their belt, they start and actually realise, oh dear, I actually really know nothing. It's the Kruger-Dunning effect. The less you know, the more confident you are. And as soon as you start to get some knowledge up, you suddenly realise, crikey, my knowledge isn't probably as good as I thought it was. Whoops, thank God I haven't made a mistake before today. So you can move yourself forward with that. And that's what I mean about planning. Like if you have a passion for palliative care and this is where you're going to be in the long term, which tends to happen with palliative care nurses, is very much looking at putting a framework in, and then it's just like, crikeys. Being a nurse practitioner might not be a bad thing, and it may become a step towards that then makes transitioning easier. This will be interesting because as it stands right now, you're someone who's worked for a lot of years, you've got a lot of experience and knowledge and clinical ability. You do your masters, which is very much, it's got very, about getting your physical assessment, getting your clinical reasoning happening, being able to defend your clinic, do your diagnoses and formulate them properly, and then the treatment plan for it. You do all that, and then someone shoves you a PBS number, and you've got to learn to write a script as well. So it can be quite a hard thing, I think, for people to transition because of course, amongst all that, you've got a good dose of imposter syndrome sitting with you. So I think something like this, if you can do it a little bit earlier on, get it a little bit under your belt that you know the safe way to write a script and then pursue it. I think it will be because I think it's going to be very, very, very different to what we do as nurse practitioners. And I guess that's
Yeah.
why I support it because I can see it as a way to allow people to access healthcare. Shockingly today, we had someone a GP refuse to give the scripts for a patient because there's a fuel crisis you're on and I'm not doing anyone any favours. So you can
Oh,
get that atrocious attitude that's quite selfish, or I just can't. And it does happen so often. I haven't seen them, or there's a locum, I must see them. And the patient can't drive, or for lots of reasons, they don't have someone to drive them, or whatever's gone wrong. And so that sort of thing is a problem. So imagine if you had a lovely nurse, a registered nurse prescriber in that area that can have a conversation with their mentor and formulate a plan. And instead of me being dragged off the complex patient I'm seeing elsewhere, they can set that plan up, do the scripts, and start working it through to that level.
yeah, it
And
makes
that's where I
sense.
think we'll get some benefit from it. And that then starts to layer in some skills building and confidence for that person who may want to become an emerging nurse practitioner in the future.
Yeah, and look, I guess one of my questions there's one more in the chat, but I guess one of my questions is going to be was going to be and this webinar I think will help people build a case because you kind
Mm.
of need to understand what you're asking for before you go and ask your manager. But I guess my question is if someone is listening today and thinks, yep, this is it, I mean, my setting totally suits this, I have the skills, I have the experience, what do you reckon they need to do first to start moving their workplace towards it? Do you think they need to go to a course? Do you think they need to speak to their manager, make their manager watch this webinar? What do you think, Jen?
Certainly, have you got a postgraduate? Are
Mm.
you sufficiently experienced in? Because one thing that came out very clearly is I've been an ICU nurse, sorry, ex-ICU nurses, I pick on you all the time, but and I was allowed to prescribe in my unit and I come and work in palliative care. I'm a prescriber now. No, darling, you're not. It's very clear that you actually need to have rubber on the road in your experience area. And let's face it, how can it's not that easily transferable. If I decided to become I don't know, older person go work in, with aged care, I would still need to do, and I'd have to get mentored again for a certain period of time to pick up the skills I don't have. And I would make sure that I did a postgraduate degree for older people just to get my knowledge up to date and to be safe to do the job I'm doing. So I think
Oh,
if you're looking towards it, have I got my ducks in the row to be the best palliative care nurse I can be? Yes, no. No, what's courses? Who can I speak to in my area that is looks like they're a good mentor. I love the way they work. I'm going to have a chat to them and see how they got to where they are and what they did. And then
yeah.
what can you emulate from those things that you can bring into your own area
Okay.
and
Yeah,
then move forward. Talking to your manager, I think, yes, you need to. You need to talk to your manager, but before I go in there, I'd actually have a bit of an idea about what you can do for them before you go,
yeah,
I want to be a nurse prescriber, because that's never going to land well. If someone said that to me, I'd be like, oh, really? And and I'm very pro because that's about you and it's got to actually be about the patients and the service at the end of the day. So what can your additional endorsement do to help the patients? Because at the
mm,
end of the day, you could do the course and people have done the nurse practitioner masters without support from their organisation. And the organisation is under no obligation to
mm,
fund your nurse practitioner position at the end, and there are no under obligation to give you an RN prescribing position at the end.
yeah.
Is the bottom line? I'll support you to do that.
Mm.
Um,
And I think that's a good point, Jen. And I think it's about framing it in a way that the organization goes, oh yeah, that makes total sense for us.
yeah, yeah.
Um,
And if you look at the side, if I can pull up the sides, I've got a copy of it here. It's a really good logical tool to actually prove your worth. So my thing would be when you state, and I think that the decides framework will probably be in the bottom of all states and territories because it's come out of APRA. But to have a look at it before you
yeah,
go to the manager, be having a look at what's in your policy directive from your local organisation or government or whoever you work for. See what they've got and see if you match up to it. Okay, I don't quite match up there. Maybe I need to find, what can I do to lift that up? What can I
yeah.
do to make myself the right person to fit into that job?
Yeah, you got to make it
I
easy. You
think
got to
that's
make it
key.
easy too. Now, Jen, I've got another question, and this one was from Chloe, and
Yeah.
Chloe very politely put her hand up, but then then I didn't answer her straight away. So thanks, Chloe, for being patient. Chloe says, for those completing RN prescriber units with a non-approved course, would it be difficult to apply through APRA for for RN prescribing rights? Oof, Jen, do you know the answer to that one?
Oh, I think possibly at the moment it would be because why it happened with nurse practitioner as well. Okay, because I'm an H&L bird. When I did mine, there was only two universities you could do your masters at to become a nurse practitioner because it was locked down, it was controlled. Obviously, I was one of the very early nurse practitioners in palliative care, so I had no choice. I went to the University in Newcastle, and that's what I did. Over the time, it's opened up. And I suspect that's what we're going to see here. Initially, it's going to be locked down to a very small number of courses, and that's to guarantee quality. That's to be, oh, this is recorded, but I'm going to put it out there. It's going to be actually to appease our medical colleagues and any other doubters of the nurse prescribers coming on board that there's a quality product that's being overseen. I suspect in 5 years' time, if we ran this webinar, I suspect the whole face of this will look very different in 10 years' time. The first people that are going to be doing it are going to be monitored up the wazoo. That is a technical name. And that we're going to, because there's going to be a lot of oversight and there's going to be a lot of monitoring. That's a reality when you're a nurse who sticks your head out of the box that people want to assign you to. So I think probably initially it may be a bit tricky. I could be wrong. If I'm wrong, happy days. I'll buy you a gin and tonic if I ever meet you face to face, Chloe. But I do suspect initially it will be, and it's just purely for quality to be able to prove to everyone else that these nurses are safe and they're okay because we've trained them to this standard.
Mhm. Jen,
Um,
I have another question. And I'm not, Jennifer might need to unmute herself, so because I don't think I fully got the gist of it. But the question says, will what asking about what the position of will be titled in organisations? And Aileen, in addition to that, will there be additional arrangements made or remuneration made in the enterprise agreements? Do you any answer to that one, Jess?
I agree, Aileen, and that's a comment that I've made back on more than one occasion. And I was part of the New South Wales arbitration review for our award last year, and I asked that, but it was just something that was too big, and because it wasn't out, it wasn't something they put in this award. But if you're doing that extra skill, you should be, I think, remunerated for it. I think that you should. And this is again my opinion, so maybe I've got a bias and I'll be proved wrong. I actually think that if you're going to be looking at this, you should be holding a clinical nurse specialist or a nurse consultant level kind of position. I
Mm.
don't know whether it says RN prescribing, but I actually think you need to have the gravitas of that higher level position to be doing this and the proof that you've got the skills and qualification to actually be able to do it. What was the second part? So money, yes, I agree with. What was the second part, Sarah?
And then,
Sorry, I went a
Jennifer,
little bit
I'm not
blank.
sure if I understood, but I think that's kind of the same similar thing. Will they have their own special title? I think what will, or is it up to
I
every
think
organisation to figure out what it?
I think it's just
I,
going to be an endorsement that you see
yeah,
on APRA.
yeah, yeah. Okay.
At this point in time, I don't think there's any, but again, it might be, but because what we're dealing with essentially is the decision to allow RN prescribers comes from the federal government, the Commonwealth, because
Yeah.
that's the APRA, it's the whole overruling body. But to enable this to happen, I can't remember, I did get told, but there's a huge amount of legislation that has to be changed at the Commonwealth level. All the Poisons Acts in the states have to be changed, and then different. So the Poisons Act. What was the other piece of legislation? There was another important piece of legislation that has to be adjusted and go back to Parliament to allow this to happen. So it's complicated. It's not just hey babes, I'd like to prescribe one day. There's a lot of work that's gone into it.
Okay. All right. Well, look, thank you very much, Jen. I'm just having a quick look to make sure we haven't missed any more questions.
Yeah. The other
Uh,
thing,
yep.
the other thing, would you like? It doesn't automatically qualify you for an MBS or PBS number at this time,
Uh,
as becoming a nurse practitioner doesn't either. So when you become a nurse practitioner, one of the first things you do is you go to you give away your firstborn child and sign your name away in blood, and you apply for a PBS and MBS numbers depending where you work through the services. What's that called? Sorry, just gone blank. PROD is the thing you go on to. Department of Community Services, would that be what it's called at federal level? Sorry, gone out of my head. If you Google it, you'll find it. And you have to apply, and then you grind through this gorgeous process that eventually hopefully spits out a PBS and MBS number at you. I think
right.
if there's anyone who's on who works in primary practice and works for a GP, I think it's going to get a bit interesting because I can actually see GPs having RN prescribers join their practice, and this is where it might get a bit iffy as a nurse practitioner thing to actually take up some of that script load for them. But I think they'll only do that if they can get an MBS item. And at the moment, for nurse practitioners, MBS items are fairly restrictive as it is. And as I've got a colleague who has, or a couple of colleagues or people I know quite closely, they've gone into the world of private, and I listen to their stories about how they adjust, adapt, manipulate, utilise, pick your adjective, MBS to actually get money out of them. And it's a skill in itself that I certainly don't have because I live in the land of being a state government employee.
Mm-hmm. Yeah.
So
Look,
it will be a bit of a trick.
so there's I guess that maybe one of the take homes is that it's still evolving, and a little bit of patience will be involved to get it, and maybe those who choose it now need to be ready to
Yeah,
kind of, yeah, that's right, to be there, to lead something that's going to maybe be a little hairy.
yeah,
Jen, there was someone just before we finish, someone just
yeah.
Monique has just asked, can we share the link for the APRA fact sheet?
Yes, I was going
Absolutely.
to try and put it on, but I'm not that clever. But I'm sure you and James are clever enough because I will put some of the handy links. There's some interesting research papers that have been done as well on this, which I had a bit of a look at as well because it's interesting. And I'm not going to pretend. Yes, I am pro, and there's at least three nurses that I work with, and I've offered to be a trial for our health district, a trial to get a nurse up and prescribing because I actually feel for me, for our service, I can see so much clinical need for it. I'm a convert. That can't be said across the board. So wherever you work, it's like anything when you want to do change, you're going to find people who do not support your idea, even if it's a good idea. And so you've just
Yeah.
got to try and get the thing of change management in your head, find who your supporters they are, work with them. The people that are sitting on a fence getting splinters in their bottom, they'll sit there until they see that you're safe and you're doing as advertised. You're being a safe prescriber, you're seeing the patients, you're doing the complete job, and you're being an excellent resource. And so they'll
Yeah.
fall off the fence into your paddock. There's going to be a very small number of people, you might drag them to the fence, but chances are you're never going to change their opinion, so don't waste your energy on them. They're outside your locus of control. And so that's what happens when you're a pioneer in anything. I think for many years I wore Kevlar underwear, a Kevlar vest, the full hat and shebang, because as an early nurse practitioner, life wasn't always friendly. You never knew where you could find someone hostile to it. So find out
Mm.
where your friends are and utilise them. For sure. The other thing you'll need to do if you do this is just me, because no other nurse practitioner does. Nah, no, any nurse practitioner has to do an extra. So everyone has to do 20 hours of CPD to maintain our registration as nurses. Nurse practitioners have to do an additional 20. Nurse prescribers will have to do an additional 10 CPD that are related to prescribing and quality safe use of medicines. There is more information on this that I've gone into today, but I've sort of tried to, as Chitra said, put it into a capsule, make it nice and small, achievable, and a bite-sized piece. Yeah. So if you want to plan, but be patient because not everyone's going to be quite see the role as you quite see the vision as you see it. So you've just got to work around that. There's no point going ramming your head and into a immobile barrier time after time again. You've got to think smart and strategic and find who your supporters are. Have a look at yourself. Have you got the skills and qualifications that you need to do this? Just putting your hand up and going, I want to do that. Is that good enough? Have you got your postgraduate? Do you need to do your master's? Do you need to look at doing another role and acting into something just to put another string to your bow?
Mhm.
Be careful. And this is what I feared. And I actually feel one of my fears about this when I first got a bit more into it a couple of years ago is that nurses in hospital wards would just have, oh, can you just discharge that patient as the doctor walks out the door? Oh, and do the scripts, will you? And just keeps walking, and that we go back to being doctors' handmaidens. I don't actually think that's a career choice as a nurse. I don't
Mhm.
support that as a career choice as a nurse. And I think we've got to look that it's an adjuvant to being a bloody good palliative care nurse. Or a very good whatever you are nurse. And that's where we need to do. It's an adjuvant to your role. Don't plan to become a nurse prescriber and sit at a desk all day and furnish scripts
Mhm.
and put them into the wind to go to the patients. That you're lining up for a career that's not terribly satisfactory at the end of the day. And if I think about my role, yes, I've had script pads for many, many years. Script writing's probably less than 5% of my day, and I can go days or even weeks sometimes where I don't, because it's all about my assessment skills. It's about my differential diagnoses, and it's about me being a nurse first. So really looking at what your nursing interventions are before you throw drugs at people. And this is particularly important if you're looking at palliative care prescribing. When I started palliative care prescribing, I walked 5 miles in the snow. No, most people with cancer obviously had quite a short trajectory. A lot of people, if you got liver mets, you died within, 2 years. If you're a metastatic melanoma, there was no hope for you. So they moved through the system really quite quickly. And that's why a lot of palliative care service were formulated around cancer patients because it was neat, tidy, and predictable. That's no longer the case. People get onto immunotherapy as a Hail Mary, and all of a sudden, when you thought, and I've been caught out by this personally, they looked like they would die in the next couple of months. They had a high lactate, they were stage 4, the Mets were in places they should never have been. They gave him a trial of immunotherapy. He's still alive 4 years later. But I
Mhm.
unfortunately thought he's going to die and started opiates and benzos as you normally do. So there's a sting in our tails, palliative care people, that you really have to think about, is this medicine? Is increasing this opiate the right thing for this patient? Is using a benzo the right thing? Because we don't want our patients to end out negatively impacted by our actions.
Yeah.
I've learnt my tale with that, and I can tell, that's another story for another day. But, this is part of our thing. It's not quite as easy prescribing in palliative care as perhaps it was when I started doing it. and go
And
from
that's
there.
a point, Jen. Like it's, and I guess there's two parts there. One is that it's a step up and it's a lot of responsibility, and it's actually prescribing in whatever context is actually quite a big responsibility and has
Mm,
quite a big impact. But then the other thing you said, which really is probably a great way to end the webinar, which is that this is totally, this makes so much sense for palliative care nurses. And this is the space that we should be leading
mm,
into, and we should be leading and stepping up, because we have skills and we have it's a team effort, and this is absolutely a space where palliative care nurses should be stepping into if it's the right for your service and your patients. So thank you, Jen, for your agenda whole full of um, everyone saying how great that session was, and your wisdom and pragmatism is very appreciated. Now, before you hop off, everybody, I just wanted to firstly say thank you to Jen. Just to say that this presentation will be available via our YouTube channel if you want to watch it, or send it to your colleagues. Um, the next session will be in 2 weeks' time, and we're going to be talking about nursing in the bush. And we've got two rural and remote palliative care nurses from the
wow.
NT coming to talk about their work. And if you want to hear about how palliative care works in a flood, that will be what Catherine from the NP will be giving us some insights into how that worked for her. And then lastly, the PCNA have a conference coming up, if you haven't heard, and Nurse Jenny McKenzie will be one of the speakers. So you can get more of Jen at the conference. So thank you all of you for joining us. Please complete the survey, and we hope to see you in a fortnight's time.
Thanks for the questions, guys. You've been great. Good luck,
Bye,
everyone.
guys.
Hope you see some of you prescribing soon. It'll be awesome.